Okay, now let's talk a little bit more in detail about the pathogenesis of rheumatoid arthritis. Although there is much tantalizing data which we can review below, it is fair to say that the cause of RA is still unknown. Nevertheless, from the vast amount of research conducted on the pathogenesis of RA, it is possible to propose a plausible succession of events that contribute to the progression of the disease. Such a scenario assumes that an undetermined microbe might be the inciting event in the development of RA by engaging the innate immune system through a toll-like receptor. For example, TLR2, 3, and 4 are present on synovial fibroblasts. Binding ligand to TLRs upregulates expression of pro-inflammatory cytokines. Cytokines, in particular TNF-alpha and interleukin-1, play an important role in RA, and drugs that block their action are now among the most powerful drugs available to treat RA. Breakdown of self-tolerance occurs early in RA, as witnessed by the presence of RF and anti-CCP antibodies months to years before the clinical disease develops. Recall that RF is an IgM which reacts against the Fc fragment of self IgG. Again, rheumatoid factor is an IgM which reacts against the Fc fragment of self IgG. The heightened risk for developing RA in association with MHC class II DR4 is localized in the third hypervariable region of DR beta chains. Now several other gene defects have been implicated as contributory factors in the development of RA. Protein tyrosine phosphatase, or PTPN22, encodes a tyrosine phosphatase that in RA is defective and therefore is unable to modulate or downregulate the activation of tyrosine kinases. These tyrosine kinases activate many lymphocyte responses by phosphorylating key proteins. PTPN22 dephosphorylates residues in tyrosine kinases, thereby inactivating the otherwise stimulatory kinases. Another gene defect associated with RA includes CTLA4, which is involved in the co-stimulation of T cells, and STAT4, involved in the JAK-STAT signaling pathway. ACPA-positive disease is now considered to be a separate entity from seronegative disease. Citrullination is believed to permit antigens to fit in the HLA alleles that harbor this modified binding site. It is suggested this reverses tolerance, allowing antibody to be formed against this cryptic antigen. Normally, the synovium is a relatively acellular structure with a delicate lining. The synovial infiltrate in RA contains abundant macrophages and fibroblast-like cells, the later displaying aggressive features such as a proliferation without adherence to the extracellular matrix. Degradative enzymes including metalloproteinases and serine proteinases digest extracellular matrix and destroy the joint surface. In addition, the osteoclast has been incriminated as a major factor underlying bone erosion in RA. Almost 20 years ago, it was recognized that TNF-alpha and interleukin-1, among other cytokines, are produced by rheumatoid synovium. Capitalizing on that finding, anti-TNF-alpha and anti-interleukin-1 biologic agents, VID-infra, have made it possible for many patients to achieve significant long-term remission. This underscores the role these cytokines play in the destructive phase of RA. For a long time there has been evidence for the participation of CD4 positive cells in the pathogenesis of RA. More recently, a particular subset of T cells, Th17, and its triggering production of interleukin-17 has become a critical focus of the progress of RA. Interleukin-17 has been shown not only to promote joint inflammation, but also to drive destruction of cartilage and subchondral bone. There is also evidence for the participation of B cells producing antibodies, which may fix complement, promoting the release of pro-inflammatory cytokines. Macrophages, as the most versatile cells of the innate immune system, also produce pro-inflammatory cytokines. To this witch's brew we must add synovial fibroblasts, which also elaborate pro-inflammatory cytokines. One of the most recent facets of the progression of RA is the set of events that underlies the role of activation of osteoclasts in erosion of bone. This is accompanied by suppression of bone formation, both prompted by the TNF-alpha. Suppression of bone formation occurs by inhibiting the expression of the WNT signaling pathway, or VEED-infra. Osteoclasts are macrophage-like cells endowed with a roughed border and an arsenal of proteolytic enzymes that bring about bone resorption. Receptor activator of nuclear factor K-beta ligand, or RANKL, is expressed by T cells, and when RANKL binds to its receptor on osteoclast precursor cells, RANKL activates osteoclasts to resorb bone. TNF-alpha and interleukin-1 promote differentiation of osteoclasts into potent lytic cells. It is now clear that in addition to bone loss, the normal countervailing process of bone formation and repair is shut down in RA. The wingless WNT family of glycoproteins is involved in regulation of multiple cellular activities that impinge on cell growth, differentiation, and cell death. Among the many organ developmental programs governed by WNT signaling is bone formation and remodeling. Here we will focus on DKK1, an inhibitor of the WNT signaling pathway. DKK is a family of 4 cysteine-rich proteins, of which DKK1 is the most potent inhibitor of WNT signaling. Once again, we see the role of TNF-alpha specifically. TNF-alpha upregulates the expression of DKK1, which by inhibiting WNT signaling interferes with bone formation by osteoblasts. Several studies have shown that DKK1 is associated with decreased bone formation, while inhibition of DKK1 with a monoclonal antibody impedes bone resorption. This research sheds considerable light on why bone destruction is such a prominent feature of RA.